So today we're going to discuss about SLE. SLE is a disease of young females. So women in reproductive age group around 20 to 40 years, they are most commonly affected in SLE. There is a female is to male ratio that is around 9 is to 1. So female are more affected. Women in reproductive age group most commonly they are affected with SLE. So other age group are also affected. Males are also affected. Children are also affected. Elderly are also affected. There is a catch about elderly SLE, and it is called postmenopausal SLE. So what happens in postmenopausal SLE? So I bring it here. As in the SLE in SLE, there is an antibody called antinuclear antibody. It is positive in SLE, but it is not positive in 100% of cases of SLE. It is positive in 97% of cases of SLE. So rest 3% is this. Here in elderly SLE or postmenopausal SLE, ANA is negative. This is the case here. In 100% cases of SLE, ANA is not positive. It is only positive in 97% of cases. Rest 3% is elderly SLE. So it has a relatively good prognosis as compared to other this type of SLE. So it is good prognosis. Why it has good prognosis? Because it has no CNS or renal involvement. No CNS or renal involvement. But in case of childhood SLE, 100% of time it progresses into lupus nephritis. Uh, in childhood SLE, it always progresses to lupus nephritis. But in case of elderly SLE, there is no CNS or renal involvement. That's why it has good prognosis. So what is seen here? Here are seen the Zika symptoms. Keratoconjunctivitis Zika, then dry eye, dry mouth, all those things. Zika symptoms. So what? Other than Zika symptom, there is serositis and musculoskeletal manifestation. Other musculoskeletal manifestation SLE, they are most commonly seen here. So in case of male, suppose a male is SLE positive, that is poor prognosis. And active SLE, suppose a patient is with active SLE, then their serology markers, anti-dsDNA antibody is positive in that case. Okay, so now we'll discuss the etiology of SLE. So this is the most important part, I think, in this video. So what is the etiology of SLE? So pathogenesis of SLE involves both genetic plus environmental factors. So both genetic and environmental factors. Genetic factors can be divided into two types. One is HLA, another is non-HLA. So what is HLA? HLA associated HLA DR3 most commonly, and that is most commonly associated with SLE. That is a genetic HLA factor, and HLA DR2 can be also there. What are the non-HLA factors? Non-HLA factors are early complement deficiency. Early complement deficiency. So what are the early complement deficiency? C1q greater than C2 greater than C4. Sorry. So these are complement deficiency that can lead to SLE. Another there is we most commonly see that SLE is affects most commonly affects young females. So what is most common in female? That is X chromosome. So in case of a Klinefelter male, there is double X chromosome. So they are also at high risk of developing SLE. So X chromosome has a association with SLE. So if the number of X chromosome increases, the risk of SLE also increases. So another chromosome is chromosome number 3. There is a gene called TREX gene that is also responsible for SLE. So what are the environmental factors that lead to SLE? So the environmental factors are oral contraceptive pills. Suppose a female has genetic factors, genetic exposure before, or their genetics is prone to SLE, develop SLE, and she takes oral contraceptive pill, then she is at a very high risk of developing SLE. Another thing is hormone replacement therapy, HRTs. HRTs, they have more side effect as compared to their good ones. So HRT are people using SLE, they are also HRT are high risk of developing. And there is UVB rage, UVB, Epstein-Barr virus infection, and silicosis, and vitamin D deficiency and smoking. There are also environmental factors which predispose to SLE. So now we'll progress the pathogenesis. So how this disease develops. I told you that two type of factors are there, genetic and environmental factors. So how these genetic and environmental factors leads to development of SLE. So first thing first. So how SLE develops? The main mechanism is defective clearance of apoptotic and necrotic debris. As we know, in apoptosis and netosis is this neutrophil extracellular trap. This apoptotic and necrotic debris, they should be cleared by these complements or other things. If they are not cleared, there is a defective clearance of apoptotic and necrotic debris. Uh, that is the first thing that leads to development of SLE. So how these things lead to development of SLE? So suppose there is defective clearance of apoptotic and necrotic bond, then there will be activation of toll-like receptor, TLR7, TLR9, they are activated. TLR7 and TLR9, when they are activated, then there will be immune dysregulation. Immune dysregulation will be there. So when immune dysregulation will be there, these TLRs, TLR7 and TLR, they are pattern recognition receptors. When they are activated, they will activate the innate immune system. Now the innate immune system is activated. There is a type of cell in innate immune system that is called plasmacytoid dendritic cell. Now the plasmacytoid dendritic cell gets activated due to TLR7 and 9. When this plasmacytoid dendritic cell, as we know, is a type of antigen-presenting cell. When this is activated, this releases a cytokine that is type 1 interferon, or it is known as interferon alpha. So this plasmacytoid dendritic cells, this releases interferon alpha. So this is the central key pathogenic cytokine. So this is the central key pathogenic cytokine in development of SLE. So what happens next? When this interferon alpha gets released, it leads to activation of various antigen presenting cells. Other various antigen presenting cells, they are activated, and it also causes endothelial injury. When other antigen presenting cells are activated, they present antigen to T cell, and there will be T cell activation. So which type of T cell most commonly affected here? There are three lineages of T cell, that is Th1, Th2 helper cells I am talking about, and is Th17. So here most commonly Th2 are affected. So when Th2 are affected, they release cytokine. Three types of cytokine it releases. One is interleukin 4, another interleukin 5, and interleukin 13. So here interleukin 4 is the main player. So what is does that? As we know, when B cell uh, becomes plasma cells, and there will be uh, class switching. One type of antibody forms another type of antibody, or class switching of those antibody. Interleukin 4 is required. So suppose there is high interleukin 4, there will be more immunoglobulins production. So these immunoglobulins will be released mostly IgG type. These immunoglobulins will be released into bloodstream. This immunoglobulin will react with this inappropriately created defective clear necrotic debris. This immunoglobulin will go and bind with that, and they will form immune complex. When these immune complexes are formed, the immune complex will deposit in various places of the body. That will give rise to symptoms of SLE. When they deposit in kidney, it will to glomerulonephritis. dependent blood vessel that is vasculitis, and in joints it is synovitis. So these immune complexes deposition is the main pathogenic factor in case of SLE. So it is called a type 3 hypersensitivity reaction. That's why SLE is called type 3 hypersensitivity reaction. So this is the basic pathology behind SLE. So this is how SLE develop. I am going once more. First, there is defective clearance of apoptotic or necrotic debris. Then there will be activation of toll-like receptor. Toll-like receptor 7 and 9. They will activate plasmacytoid dendritic cells. This is a part of innate immune system. When the plasmacytoid dendritic cells gets affected, it releases a cytokine that is interferon alpha. Interferon alpha leads to activation of other antigen-presenting cells. When other antigen-presenting cells are affected, antigen-presenting cells they present these antigens to T cell. Now, when T cell is sensitized, it will activate the B cells. T cell can activate B cell by various mechanism. Another mechanism CD40, CD40 ligand. This is present in T cell and CD40 receptor. It is present in B cell. So this is also how can T cell activate B cell. Another mechanism is T cell really TS2 cells release interleukin 4 that will lead to increased class switching of antibody and other antibody formation. These antibodies will form immune complexes, and these immune complexes go and deposit in various places of our body that will lead to full-fledged SLE. So how will you approach to SLE? How will you diagnose SLE? As we know, this is the pathophysiology behind SLE. So how will diagnose in case of SLE? Suppose there is a clinical suspicion. Suppose, suppose we have high clinical suspicion that this we may have SLE. Suppose we have high clinical suspicion that this patient may develop SLE. So what are the symptoms? Most commonly, there symptoms skin manifestations and non-scarring alopecia, joint pain. It can also present autoimmune hemolytic anemia, secondary ITP. It can present with anything. Okay, SLE can present with anything. Young girl present with this kind of symptoms, we will suspect first SLE. So first thing first, we have to do an anti-nuclear antibody assay. So how will detect ANA? So suppose we detect ANA and appearance of antibody. Another thing is that this ANA antibody, this is not diagnosed. Suppose someone is ANA positive, we cannot say she is having SLE because appearance of antibody is before onset of clinical features. In SLE, ANA appears before 3 years of before the onset of disease. Suppose disease will develop in 17 years. This will appear before 3 years. 14 years, ANA will be complete. Suppose you will test all in 14 years, there will be ANA only positive. And it is very non-specific. ANA is positive in various cases. Okay, so ANA positive in various cases, so it is very non-specific and it comes before the onset of disease also. And Sjogren syndrome, it is positive antibody appears before 10 to 15 years of development of disease. So ANA positivity is not the accurate way to say someone is having SLE. There are few cases in which if the people suppose 100% cases they have ANA positivity. I said 97% of SLE have ANA positivity. Uh, in which diseases there will be 100% ANA positivity. There are three diseases in which there is 100% ANA positivity. So what are they? It is mixed connective tissue disease, type 1 autoimmune hepatitis, another is drug-induced lupus, or drug-induced lupus erythematosus. So these are three diseases. One is mixed connective tissue disease, another is type 1 autoimmune hepatitis, another is drug-induced lupus. These three things, they have 100% ANA positivity. And Sjogren ANA positive in 85% of cases, SLAS and 97% of cases is ANA positivity, 100% cases in MCTD, type 1 autoimmune hepatitis, and drug-induced lupus. And IgG4 related disease, 50% cases are ANA positive. So this is all about ANA positivity. So as we know, there are various diseases in which ANA can be positive. Suppose someone comes ANA positive, we can say he's having SLE. That's why I'm telling all these things. Suppose we have high clinical suspicion, then we test ANA and it comes to positive, and ANA comes positive. So at the next step. So how this ANA can become positive? How in which method you tested it? There is ELISA and that's indirect immunofluorescence. ELISA is not the correct method. Indirect immunofluorescence. Suppose ANA, if ANA is positive in indirect immunofluorescence using human epithelial two cell line, the cells are derived from human having carcinoma larynx derived from these cells. In indirect immunofluorescence, have two cell lines derived from human carcinoma larynx patient, and the ANA titer is more than 1 is to 80. In this case, we say it is ANA positive. ANA positive means you should be tested on indirect immunofluorescence using human epithelial 2 cell line, HEP2 cell line, and cells are derived from CL larynx human, and the um, titer of antibody should be more than 1 is to 80. Then we look for the pattern. Then we look for the pattern. So what is the pattern of immunofluorescence? That is the most important thing. So what is the pattern of immunofluorescence in case of ANA positivity? There are various patterns. Suppose one pattern is dense fine speckled pattern. Dense fine speckled pattern. Suppose AN is between dense fine speckled pattern, it rules out connective tissue disease. Okay. Then suppose it's fine speckled pattern. Fine speckled pattern. Uh, then it can be anti Rho or La positivity. We have to test further these antibodies are positive or not. Okay. We suspect that this can be positive because this pattern is in an immunofluorescence. Anti-Rho antibody positive, then there can be Sjogren syndrome can be there. Another is coarse speckled. If the pattern of immunofluorescence is coarse speckled, uh, then uh, then there will be three possible cases. One is anti-Smith antibody. It is a specific antibody in case of SLE. Then SLE can be there if ANA shows coarse speckled pattern. If it shows coarse speckled pattern, there can be anti-UN RNP. It can be due to MCTD, misconfigured tissue disease, and anti-RNA polymerase 3. This can also lead to systemic sclerosis. So these are few patterns. There are other patterns also. I will discuss that also. So these are few patterns. So what are the other patterns? Another pattern is anti-nucleolar. Anti-nucleolar pattern on indirect immunofluorescence. Anti-nuclear pattern means mm, PM or SCL. Polymyositis or scleroderma. Anti-nuclear pattern. So once in if ANA positive in an anti-nuclear pattern, a nuclear pattern, then there will be polymyositis or scleroderma. And suppose there is anti-cytoplasmic, suppose there is anti-cytoplasmic, then it is anti-Jo1, it is polymyositis and dermatomyositis. Suppose there is homogeneous pattern, ANA positive in homogeneous pattern. Suppose ANA positive in homogeneous pattern, there can be two antibodies here. One is anti-dsDNA antibody, another is anti-histone antibody. Anti-histone antibody seen in drug-induced lymphocytomatosis, anti-dsDNA another specific antibody in case of SLE. And suppose there is anti-centromeric pattern in immunofluorescence. Suppose there is anti-centromeric pattern in immunofluorescence, it can indicate CREST syndrome. In case of CREST syndrome, there will be anti-centromeric pattern. So suppose there is dense speckled pattern, then we will have connective tissue disease. Fine speckled pattern, anti-Rolla, it can be Sjogren. And suppose there is a coarse speckled pattern. In case of coarse speckled pattern, there will be anti-Smith antibody positive. That can be a specific antibody in case of SLE. Anti-RNA polymerase antibody, that is RNA polymerase 3 antibody in systemic sclerosis. Anti-UNRNP, that is in case of MCTD. Anti-nucleolar antibodies seen in polymyositis and scleroderma, anti-cytoplasmic antibody, anti-cytoplasmic pattern in immunofluorescence, that is antibody is anti-Jo1 antibody. It is seen in polymyositis, dermatomyositis, homogeneous pattern of arrangement of antibody, antinuclear antibody. Homogeneous pattern, there are two things. One is anti-histone antibody, another is anti-dsDNA antibody. Anti-histone antibody indicative of drug-induced lupus. Anti-dsDNA antibody is seen in SLE. And the other specific anti-centromeric antibody seen in Rett syndrome. So these are all patterns of antibody. Suppose we have high clinical suspicion and we tested ANA through this, ANA became positive. And this many pattern are possible now. So now we'll test the antibodies ANA profile. We'll do the ANA profile. We'll look for the antibody and match with this. Is this matching on? This is done by immunoblot technology. Immunoblot technology, and we'll analyze multiple antibody, and now we'll know which kind of cell is there. Suppose a patient comes, she's taking procainamide for a long time. It's an antiarrhythmic drug, and later that she developed the features of SLE like rash, joint pain, other symptoms of SLE, autoimmune hemolytic anemia, or secondary ITP. All these things it develop. Now she comes to you. You suspect it's a drug-induced SLE. So first, what we will do? First, we will test whether she is NA positive or not. We'll test NA positivity by immunofluorescence, indirect immunofluorescence using HEP2 cell line derived from human carcinoma larynx cells. The titer of ANA should be 1:80. After you suspected ANA positivity, now we will look for the pattern of immunofluorescence. So the patterns will be homogeneous in case of drug-induced lupus. So there will be homogeneous pattern of anti-nuclear antibody. In case of homogeneous pattern, there are two things possible. One is anti-DHD and anti-histone antibody. Now we'll do antibody profile, AN antibody profile, and there will be anti-histone antibody. Titer will be high. Now no anti-histone antibody is there. Now this is uh, that will give that will confirm our diagnosis of drug-induced lupus erythematosus. In 100% cases of drug-induced lupus erythematosus, there will be positivity of ANA. So now we'll withdraw the drug and the symptoms will recede. So this is all about this. So what are the clinical features of drug-induced lupus erythematosus? So 100% of cases of ANA positive, I told you that homogeneous pattern on indirect immunofluorescence is there. Anti-histone antibody is positive. Cause is procainamide. And there is a drugs called CYP drugs. Sulfonamide, hydrolazine, isoniazid, procainamide. These are causing drug-induced lupus. So in elderly SLE, I told you anti-Rho positive. It has good prognosis, no CNS or renal involvement, and good from serocytos. Symptoms are Zika symptoms, keratoconjunctivitis Zika symptom, and there will be serositis and musculoskeletal manifestations are also there. And here it is, that is ANA negative. So now we'll go to other antibodies in SLE. That is specific antibodies. One is anti-dsDNA better than anti-Smith. Suppose as more sensitive antibody, that is anti-nuclear antibody. More specific antibodies, anti-dsDNA greater than anti-Smith. And we'll look for that in ELISA. Uh, Titer will see both antibody. And in 75% of cases, it is more sensitive. And it is in 25% of cases, anti-Smith antibody. And suppose there is high titer, and it has a role in prognosis also. Suppose there is high titer of anti-dsDNA, there is increased chance of development of lupus nephritis and vasculitis. The immune complex 2 are deposited in the blood vessels that lead to vasculitis. And another thing is anti-rolla. It is seen in Sjogren, asymptomatic patient. It is non-specific SLE, indicates secondary Sjogren um, in pregnancy pregnancy to another thing that are not important for us. Uh, Largely mother it is positive in sugaring also. Another is antiphospholipid syndrome antibodies. Positive in one third of SLE patient. We'll discuss about APS later. So now remember that it is positive in one third of SLE patient APS and anti-RBC antibodies that will lead to autoimmune hemolytic anemia, warm type. There is anti-platelet antibody that will lead to secondary ITP. I told you before. Other causes of secondary ITP are SLE, HIV, hepatitis C virus, H. pylori, and RA. Antihistone antibody, I told you, drug induced anti-ribosomal P antibody is in SLE with psychosis or neurological manifestations. Another is anti-glutamate antibody or anti-neuronal antibody. It is most common in CNS lupus. So this is an antibody. So also the CNS manifestation of lupus, that is cognitive decline, and other biomarkers are anti-DS DNA titer. I told you this is prognostic marker. Decrease C3, decrease C4, increase ESR, and decrease CRP. Decrease CRP because antibodies are also formed against C-reactive protein. So in SLE there is decrease CRP and increase ESR. So these are the manifestations. These are how we'll diagnose SLE. And now we'll discuss about the clinical manifestations. I told you before that constitutional symptoms, fever, night sweat, weight loss, they will be present. Other cutaneous manifestation are lupus specific and lupus non-specific. Lupus specific are SCLH, SCLA, and SCLA. SCLA is acute cutaneous lupus erythematosus, chronic cutaneous lupus erythematosus, subacute cutaneous lupus erythematosus. These are the lupus specific and photosensitive rash and localized SCLA can be localized or generalized. Localized SCLA we see malar rash and malar rash is butterfly rash associated with younger age group and seen in malarians and spares the nasolabial fold. Another case is generalized SCLA. It spares knuckles. It spares nasolabial fold. It spares knuckles. Another is toxic epidermal necrosis, that is a severe form of SCLA. And CCLA is discovered lupus. CCLA discovered lupus. Discovered rash is seen here. And scarring lupus is seen in discovered lupus. And 5% of patients with discovered rash have SLE and 20% of patients with SLE have discovered rash. It affects face, scalp, and neck, and there is a risk of discovered rash progressing into squamous cell carcinoma. So we do a skin biopsy to rule out that also. Another SCL is subacute cutaneous lymphocytomatosis, and that is also non-scarring. So unexposed fat also uh, rash, that is highly photosensitive rash and sparing of mid-facial region, and it is not very ugly looking like other two things. So these are the skin manifestations. Another is musculoskeletal manifestations. Musculoskeletal manifestation is Jacob's arthropathy. Jacob's arthropathy is seen in SLE and organ system involvement that will lead to bad prognosis. Organ system involvement leads to bad prognosis. Suppose kidney is, if it is involved, it will progress to CKD and will give immunosuppressive drugs that leads to infection and most common cause of death in first 10 years of disease, that is lupus nephritis, and there will be accelerated atherosclerosis. Acute coronary syndrome can also develop. Long parenchyma is paired in SLE, but there is a thing called shrinking lung syndrome that is associated with SLE. Most commonly, Rho, that is Rho antibody in elderly, that is shrinking lung syndrome in SLE. Otherwise, SLE spares the lung. Under vascular manifestations are APS, antiphospholipid antibody syndrome, there will be thrombosis, and the most common cause of inherited cause of thrombosis is factor 5 Leiden mutation. Most common acquired cause of thrombosis is antiphospholipid syndrome, antibody syndrome. Okay, and there will be vasculitis. Vasculitis there can be small vessel mediated on large vessel or medium vessel. Medium vessel or small vessel are most commonly seen in SLE. Palpable purpura seen in SLE. That is HSP, Enos purpura, cryovolunda, they are also palpable purpura. And medium vessel, that is medium vessel affects the CNS and mesenteric vessels. Other hematological manifestations are, I talk about the blood vessel manifestations. There are a lot of hematological manifestations. That is anemia of chronic disease. Anemia of chronic disease is present. Rapidly progressive autoimmune hemolytic anemia, warm antibody type IgG, and WBC shows leukopenia or lymphopenia. Lymphopenia is another criteria for SLE, lymphopenia or leukopenia, and there is increased risk of transformation into DLBCL, DLBCL, diffuse large B-cell lymphoma, Sjogren, that is, if SLE is associated with Sjogren, then it is a high risk to transform into DLBCL. DLBCL, other things that can transfer to DLBCL are mantle cell lymphoma and Hashimoto's thyroiditis. Mantle cell lymphoma, Hashimoto's thyroiditis, and Sjogren. They can transfer into DLBCL. If Sjogren is associated with SLE, then risk is increased. And in case of platelet, there is secondary ITP. I told you that before. Lung parenchyma is most commonly spared, and then pleuritic chest pain can be there. Um, and cough or hemoptysis then can be also there, and cardiac manifestations are Lehmann-Sachs endocarditis. That's vegetations in both upper and lower part of valve leaflets. Myocarditis can be associated with anti-Rho antibody. Vegetations are present both above and under surface of valve leaflet. Mm, and then it can develop into mitral regurgitation also. GIT is not, it is spared. Hepatobiliary is, as told you, ANA associated 100% of ANA is positive with type 1 autoimmune hepatitis. Another is renal. It is most common, mostly it is affected renal. Renal biopsy is indicated if proteinuria is more than 1 gram per day, and proteinuria more than 500 milligram per day plus more than 3 RBC in urine. Macrohematuria plus proteinuria that can lead to SLE. So there are six type of lupus nephritis divided into uh, six type. First is minimal mesangial, second is mesangioproliferative, third is uh, dif, uh, third is focal proliferative, fourth is diffuse proliferative, fifth is membranous type, sixth is advanced sclerotic lupus. So minimal mesangial, mesangioproliferative, focal proliferative, diffuse proliferative, membranous lupus, and advanced sclerotic lupus. So first two are asymptomatic, minimal mesangial and mesangioproliferative, and there is an excellent prognosis. And focal lupus means less than 50% of glomeruli affected. Focal means that less than 50% of glomeruli affected. And diffuse means more than 50% of glomeruli affected. And it is the most common type. Type 4 is the most common, class 4, type 4, and it requires immunosuppression. Immunosuppressive therapy that can also lead to other complications. And membranous, it has also better prognosis, and it has the worst prognosis. Advanced sclerotic has the worst prognosis, and type 4 has the second worst prognosis, and excellent prognosis in type 2 and 2, and poor prognosis in type 3, and type 5 has better prognosis. So in class 3 and class 4 leukonephritis, there is endocapillary and mesangial proliferation of histopathology. Immunofluorescence or IgG, IgA, IgM, C1q, C3 deposit. It is called full house effect. It is called full house effect. And also it is seen in HIV. Also full house effect also seen in HIV. And electron microscopy shows soft endothelial wire loop lesion, most commonly wire loop lesion seen in type 4. And another thing electron microscopy that is seen is fingerprint. Fingerprint like pattern in electron microscopy is a classical feature of lupus nephritis. And CNS features are cognitive decline. CNS features is cognitive decline and risk of increase of a stroke due to apply. And these are the things for SLE.